All right. Good morning. Pleasure to be here. I'm really happy to be able to spend some time to describe the Sentry system to you all. This is a new AI-assisted brain tumor surgery device. My disclosure is I have a close relationship with Reveal Surgical, the company that actually makes the device. Everybody in this crowd knows that decreasing the volume of residual tumor with operations increases overall survival, and that effect has been demonstrated in multiple studies over the last 20 years. But I think this multi-institutional study presented by the Rano group a few years ago demonstrates 3 times greater survivals with decreasing the residual tumor. And basically they were able to show that if you can remove all the contrast enhancing tumor and minimize the amount of non-contrast enhancing or T2 flare tumor, you can have a significant impact on patient outcomes. I believe that these numbers can be pushed even farther. And I just like to share this slide with you, which is a cellular view of what glioblastoma is really like. And we use these MRI features a lot as our guidance of post-surgical outcome, but what really underlies these signals. And so on the left, you have an MRI of a patient with a very classical ring-enhancing glioblastoma with a significant amount of probably infiltrative disease that is represented by the T2 flare changes. The yellow boxes, or if you can see my cursor, yes, you can. The yellow boxes are basically what you see on the right. So these are large resections where the histology has been correlated to the MRI features you see there. So this image right here, this is the H&E that corresponds to the yellow box, and you can see the necrosis. This represents the contrast enhancing tumor, and this is the non-contrast enhancing tumor, or so we would assume. The image beside it is in situ spatial transcriptomics. This is MERFISH. And so this is a gene panel of 500 genes. We can annotate every single cell that's in the sample. All the different types of cancer cells, the necrotic cells, the inflammatory cells that are associated with the tumor, and importantly, the normal adjacent brain. And with that, we can quantitate exactly how many cancer cells there are in a given field. And the overall dimension of this is around 1.2 centimeters. So you can appreciate right here, we have around 6 millimeters of brain adjacent to the contrast enhancing tumor. This is the T2 flare. And unfortunately, in the large majority, if not all patients, this is what remains after surgery. And we know, well, these are the cells that are resistant to radio and chemotherapy. The important images for you here are on the bottom. So again, every cell is represented by a dot. And I'm highlighting here the transcriptome of cells that are representing glioblastoma stem cells. These are the most active cells in the tumor. They're the ones that are cycling. And here's actually cells expressing a cycling profile. And these are not immune cells, by the way. These are all cancer cells. So in the context of a Rano classified, grade 1 complete resection, this is what remains after surgery. In fact, there are as many cycling cells adjacent to the contrast enhancing tumor as there are in the contrast enhancing tumor. So we need a major rethink on how we talk about surgery for these diseases, because we are really removing a very small portion of active tumor cells. In addition, we can't just use T2 flare as an indicator of where there are invasive cancer cells. And I show you this image of a grade 2 astrocytoma that I believe was completely resected, except for this portion right here. That's the yellow line. So this gyrus containing T2 flare was not removed. No adjuvant treatments here, and many, many years later, that T2 flare is gone. Obviously, there was no cancer there. So T2 flare is also just a marker of inflammation. Practical perspective. While everyone will talk about these as diffusely infiltrative tumors that are hemispheric and cannot be really treated with surgery, the fact is over 90% of all recurrences of glioblastoma happen where the surgery stopped at the resection cavity margin. And I've just given you 3 examples right here. These are the immediate postoperative MRIs, and pretty much every patient is going to have a resection at the margin, which corresponds very well to the in situ transcriptomics features I showed you. That's where the majority of the residual cycling cells are. Now, maximizing extent of resection or minimizing VOR can be very straightforward. You can have tumors that are in relatively non-eloquent territories that have such a burden that the actual entire lobe can be removed and patients can have excellent outcomes. That's the image on the right. But by and large, this is what we're dealing with. Difficult glioblastomas in very elegant brain territories where it's very difficult to see the difference between what's contrast-enhancing tumor, infiltrative tumor, and adjacent structures like, caudate and cretamen. And this is an astrocytoma. We have the same problem in IDH mutant tumors as well. So these are very challenging cases, and anything that we can do to allow surgeons to have better, safe surgeries will be valuable. And so 13 years ago, we set out on developing a device that will allow us to do so. And we had some fundamental principles that we thought would be important to incorporate into the design of such a device. And so one, we had to be able to identify what was tumor versus normal brain before actually removing it from the patient. Obviously important. It had to be easy to use. It had to be fast, a very small physical footprint, not only in the OR, but under the microscope for a surgeon to use. We wanted it to be like a bipolar cautery or micro scissors. Minimal disruption to workflow, meaning super fast, and be able to operate under white light. We want you to be able to see what you're doing while you're doing the operation. And so here it is. This is the Sentry system. Basically, what you do is it's a stylus probe that interrogates an area underneath the contact site. This is what the device looks like, and this is the output. Basically, it's going to be tumor versus normal brain. How did we do it? We have three core innovations. The device uses Raman spectroscopy to identify a molecular signature that is in the interrogation site, which includes lipids, proteins, genomic material, etc. Anything that can be used to distinguish between different types of tissue. There's a spectral analysis that we use with machine learning algorithms that will allow you to distinguish one type of tissue from another. And so all of these samples are anchored in ground truth neurohistopathological analysis and differentiated tissue libraries. So we've done thousands and thousands of samples of brain tumors and normal brain. We've also done breast, colorectal, liver, prostate, photocortical dysplasias, pituitary adenomas. So the library that we've been able to assemble, over 20,000 data points over the last years, is large. This is how we do most of the work. So there's a sample, there's a Raman spectrum, and it is a correlated or co-registered biopsy, which is sectioned into at least 3 different sections that are analyzed to show tissue homogeneity, and machine learning algorithms help us to have the output. This is a video of how you acquire a signal. So this is post-complete resection in my mind of a glioblastoma. Not sure though, probe the margin. And so this video is sped up, but just so you know, the time it takes to acquire a signal is less than 3 seconds. And you can just probe your entire resection cavity margin and you will have a readout that will tell you what the nature of the underlying tissue is. And so over the years, we've identified a common Raman spectrum signature that is applicable to glioblastoma, metastases, and meningiomas of varying grades. The positive predictive value for a tumor is almost 100%. The predicted value of normal brain is 100%. And keep in mind, this is for tumors. This is for, when you say tumor, we mean greater than 90% tumor. In addition to that, we've also gone beyond the contrast enhancing edge. Just to circle back to the original Murfish, I realize this is a busy figure. I'll take you through it, though. It's quite straightforward. This is, again, a glioblastoma. These are 3 points that were interrogated. I believe the entire contrast enhancing tumor was removed. I did not plan on considering that a location goes significantly beyond contrast enhancing tumor. And this is the postoperative MRI that shows indeed all of that tumor was removed. Once the operation was finished, different sites were probed and biopsies were taken and subjected to Murfish analysis. A histologist or a neuropathologist looking at these slides would say no tumor on any of her. When you use the Murfish analysis, actually, you can appreciate that this top sample had around 15% tumor cells compared to normal brain or inflammatory cells. This one here is about 50% tumor, and this one on the bottom is around 25% tumor. We were able to detect the tumor in all of these with the Raman device. So we can go beyond contrast enhancing tumor with this device, and I think that is going to be very meaningful for outcomes. And so this is a video. Good. All right, looks good. Of the actual device in action. This is the operative microscope field. That's the device in my hand there. And on the bottom is the output. And so you see, you just go back and forth and you will get a readout that says tumor versus normal brain throughout the nature of the operation. So I generally, it's pretty obvious in most cases to understand what bulk tumor is, but when you lose your certainty, you no longer have your navigation, at least with any accuracy during an operation, you become wary of continuing your surgery in super important territories. And so this device allows you to at least assist you in understanding what is that white tissue that you see in front of you. And so all of these are normal spectra. And what I find quite remarkable about this is certain areas of the resection cavity you're seeing here are completely normal. I thought they were normal, and the result there is tumor. And you go to similar areas that you are circumspect to you thought you completed the resection, and you're getting back normal. So the invasion around the resection cavity margin is not uniform. Different areas have different features. And so here, the second half, you're going to see a bunch of signals that are come back. The tissue under the microscope looks identical, but in fact, the Raman spectra shows you that is normal tissue. And so I will move from there. The stylus is one device. We've developed other devices as well that could be used for endoscopic surgeries, transnasal surgery. So this is an endonasal probe. These are examples of the device being used in robotic surgeries for GU and other types of abdominal surgeries and thoracic as well. And so for the brain application, we'll be launching a pivotal trial in spring of this year, 2026. You can please feel free to visit our booth, number 117, and the QR code. If you're interested in this, we're interested in your feedback. And so this is a way to connect with us. There's a survey that you can fill out to see how our device could be used in your applications. And with that, thank you for your time.